Facial architecture or shape is deemed the most important factor in conveying an impression of youth, along with health, vitality, and often beauty. Although folds and wrinkles are important to correct, they are almost never as important as overall architecture. Strategies for restoring a youthful shape include traditional soft tension suspensions and newer soft tissue augmentations. In this masterclass, Dr. Little focuses on the techniques he prefers to accomplish these goals.
So reshaping the aging face and neck in the safe, simple, superficial subcutaneous plane. You can throw in that modifier. It is old. With simple anatomy, simple technique. Now, I know about superficial. It doesn't get any respect. It never has had. But I performed hundreds of facelifts in each of the three facelift planes, the subcu, the SMAS, and the subperiosteal, published in a couple of those planes. And yet I find the superficial the most powerful for reshaping architecture, which is the most important thing that I do, and also for repositioning the slumped oral commissure, which is the most difficult thing I do in a facelift, for resuspending the lower SMAS and platisma, which is counterintuitive, but I'm going to try and show it to you, and finally for longevity results, which is also counterintuitive, all in the superficial plane. When I look at my goals, they sort of run like this. Facial architecture is number one for me, and the lower facial curve is more important than anything up in the cheek. The expressive features come next, the eyes and the mouth. The eyes, as I mentioned just in the last talk, are equivalent for me, upper and lower lid. Either one's more important. With the mouth, the position of the mouth is a little more important than what you do to the lip. And sometimes the mouth predominates, but a little more often, the mouth predominates over the eyes, and sometimes it's the opposite. The neck is down there at number 4 for me, and finally the surface aspect's number 5. So I know a lot of you won't agree with that priority list, but I'll try and justify it. So facial architecture is number 1, with the lower facial curve by far the more important component. Our first assessment of a person's face, age, vitality, health, beauty, etc., occurs as an instantaneous snapshot, and it's based largely on facial architecture. It's learned at an early age, and it remains unconscious until we're taught to see and recognize it, and I've been trying to get people to see it for a long time. I've been using these balances forever, and when we look at facial rejuvenation, we've got a strategy between suspension and newer concepts of augmentation and reduction. But for me, consistently, the suspension bucket is much heavier than the augmentation or the reduction bucket, certainly for the upper cheek, certainly for the lower cheek as well. In other words, traditional surgical suspension, traditional facelift is far more important to me than reducing the jowl, although I used to do what Joel did years ago. I really believe in suspending it instead. And said another way, I believe in facelift, and I want to lift all this stuff. I want to lift the jowl with its marionette. I want to lift the commissure with its bitterness fold. I want to lift the nasal labia. I want to lift the mouth with its upper, but particularly lower lips. I want to lift the chin pad, and the platisma, and the lower SMAS, and the skin of both the face and the neck, and the temporal brow, because all these things undergo descent. And I consider soft augmentation strictly a secondary tool, an inappropriate substitute for lifting, except around the orbit, as we talked about in the prior session, where there was a lot of agreement. So I believe in facelift. But what about universal ideals and all? Well, simplified, it's an inverted cone of youth, as the artist refers to it, with a graceful curvilinear cheek profile, an OG curve perhaps, and a delicate jawline. I've had to add that latter part. And the hen's egg is a good metaphor. Narrow point's young, down, the broad point down is old. So the one on the left becomes the inverted cone of youth, and the right is the squatting cone of age with the jowls, egg for young, egg for old, if you will. And it's not the only time the egg has been used in facial analogies, because in many of the masters from the Renaissance, in this case Piero della Francesca, show the egg over the Virgin's head, and that's in the Cathedral of Brera. And you can see this is the way for the artist to recognize Mary's divine natural architecture. And so that's used a lot in the Renaissance. So a young woman becomes old. And then a long time ago, she was made to look younger. And it's not a wonderful result, but the curves are good. A long convex curve, a short transition at the occlusal plane, and a short concave curve. And the name for that curve architecturally is OG. And I've focused too long on the upper cheek. It was wrong. The lower curve is far more important. Enough so now that for me, the superior part of the curve I treat rarely. I do a mid-face lift one a year. I add fat to that area in only 25% of patients, and 75% I don't do nothing. But in the lower curve, I lift the jowl on everybody. Once in a while, I reduce it a little bit. That's less than 2%. For me, relief of the jowl is a sine qua non of a successful facelift. Without it, we haven't really done much for the patient. Mary's got a jowl, Queen Mary. Now, the fundamental facial aging is architectural or structural rather than superficial or surface-based, and the architectural changes are predominantly soft tissue changes as contrasted with the orbit, where bone is quite important, particularly in the upper lid. The jowl presents the visual focus of structural aging, and therefore it has become at least my critical target, my sine qua non for reversal, because direct vertical redistribution of jowl soft tissues brings a powerful illusion of youth to the face. So I like to treat the jowl directly, detaching it from the skin, using purely vertical vectors to a nearby destination, the base of the nose, all in this paramedian amphitheater or arena, as opposed to more traditionally leaving it attached to the skin, treating it obliquely at some considerable distance and indirectly by way of the SMAS layer or by way of heavy sutures of a max lift, for example. So I just have a different take on my approach to shifting the jowl. So an architectural facelift is a superficial subcutaneous en bloc, not a SMAS, stacking, tension-free, by the way. Well, of what? Of lower facial redundancy, what we think of as the jowl, and where? Higher up in the submalar midface, not the malar, but the submalar. It won't reach to the malar. With the option of adding more fat in 25% or reducing a little fat in 2%. It's done in the superficial plane as a low transverse subcutaneous plication, and it fills a submalar deficiency of aging. With what? It fills it with the jowl. You move the jowl into that area of emptiness, thereby emptying the jowl. It elevates the commissure, which is one of the most important things we can do, and defines the jawline and corrects the neck in many. And finally, it tailors the skin because it involves wide undermining to be able to accomplish it. It's been my basic facelift now for 19 years, and if you look at my initials, they spell the operative thing here, which is jowl. And for my patients, it's an external jowl lift or an XJ lift, emphasizing that I treat it from the superficial side. For you colleagues, it's a vertical paramedian lift or a paramedian lift under the subcutaneous plane, emphasizing the position of the vector up close to the midline, as opposed to more traditional. Okay, the puzzle of the jowl for a minute. Well, there are a lot of things that go into a jowl for me, more than just the jowl. There's the obvious displaced cheek volume. There's a pillow down there out of position. There's a commissure slump frequently, often accompanied by a bitterness fold, and many times a marionette line accompanies that jowl, and there's segmental jawline ptosis. I don't believe in the pre-jowl depression, or at least I almost never put fat there, and I'll try to speak to that during the talk. The chin pad falls down, the lower lip falls down. All these things fall down in concert. The submental plane falls down, and there's platisma banding that becomes evident, and there's a submalar deficiency above from whence all this movement. Now, this is the last case I did with no fat graft to the face, so she was seminal for me. That's the year 2000. And her eyes looked terrible because I was just then beginning to deal with the eyes, but if you cover up her eyes, it's a pretty good replica of what she looked like as a young woman. So that was a time for me when I felt I understood a good bit about the cheek and the jawline, but I had a lot to learn about the eyelids yet. So the jowl for me is a structure of the superficial subcutaneous face, and it responds optimally to simple subcutaneous rhodectomy with simple vertical subcutaneous plication. I use a running 4.0 PDS. I used to use interrupted 5.0 vicryl. With occasional direct scissors sculpture, 2%. It's 50 simple. It was reported by Alfrick, 1960, and for me it's back to the future, a little as Joel, in fact, has literally returned back to his future. So a kid plays a trick on the father. They're having a party that night. Everybody's going to put the coats on the bed. So he puts the pillow in the middle of the bed under the spread. He knows the old man won't know what to do, and he doesn't. He comes, takes a look. He knows he's going to be in trouble with his wife. So he calls his buddies to come over, and they all work as hard as they can to eliminate that inappropriate bulge, and not with a lot of success. The housekeeper hasn't left yet. She knows instinctively what to do. She unmakes the bed past the bulge. She repositions the bulge gently where it belongs and remakes the bed. And you say, well, duh. But that's my approach to facelift, and I don't see a lot of others embracing this concept. Undrape, reshape, redrape. We do it in breast. We do it in other areas, but that's my approach to the face. And what's the anatomy on this? Well, the premaster space described by consummate anatomist Brian Mendelsohn and colleagues relatively recently. We have a glide plane just like we do in the prezygomatic space. It explains why the platysma with its overlying fat falls down and forms a jowl. It also explains why it's so easy to correct it. It doesn't require release. If it fell down in the first place, it should remain resuspensible without release. That's a criticism of some of the concepts of smash lifting, and it does. So my subcutaneous rhodidectomy does involve a lot of manipulation of the fat layer, unlike Joel's. I undrape the face, I mark the jowl. In the sitting position, I mark the incision. I also, Joel, never use a pretracheal incision, nor do I use a posterior extension either, out from behind the retroauricular sulcus. Not for 20 years at least. I've eliminated a lot of the facelift incisions I was thought were necessary. I mark the undermining. I go out to the commissure as you do, and beyond the jowl, and 2 finger breadths is enough for me, into the neck, if I've got a problem neck. So it's wide undermining, and I undermine the face, and then in half remove some central fat from the neck by liposuction. I divide the platysmal muscle in 60% of patients and hitch the muscle in 85% of patients. But what I really come here for is this. I draw a blue line from the base of the nose to the base of the ear, and then assess how much redundancy there is in the fatty layer. I mark that, and then elevate the one line to the second line with simple running 4-0 PDS. And that's my facelift, and it's transfacial. It's across the whole face with a purely vertical vector. If you've never seen anybody put a suture in fat and tie it before, I'll show you that. I'm only going to show you one. I refuse to show you more than that because it's really sort of simple and sort of stupid. So that's a bite in the fat. I reach down, I'm up close to the nasolabial fold, and simply take what I feel will allow closure without creating tension. I am against tension in the face. I don't use it in the face. I use it in the neck. I don't use it in the face. I used to, of course. I used to do smash surgery and all of these other things, but I no longer do. So I tie that suture so that it comes together without resistance, so that it doesn't flatten either. And specifically, it isn't tearing out of the fat, or it's not breaking, even though it's a delicate suture. And then I simply run that back to the ear. The early part is up, the important part is up front. So the nasolabial, as I progressively approach the ear, those sutures are less and less important. Because nothing you do in front of the ear is very important. I remove jowl fat in 2% of patients with extreme jowls, and then I divide the DAO in everybody. And that's not my idea. It's Claude Laurent's idea, a Parisian plastic surgeon. And then I hitch up the upper border of that cut muscle with a 4-0 permanent suture and plug the gap with something from the discard specimen. So that's my facelift. It's had a lot of emphasis on what I'm doing around the mouth. What are the technical challenges to this? Well, there's only one. It's the undermining, and that's a bit of a challenge, I think, in all of our facelifts. I mark the jawline notch, I mark the sternocleido, and then from that jawline notch, I set up what I consider the thin plane, the thin zone, and that's the zone of a little bit of danger. I do the posterior zone with a bovie. I do this with a Metzenbaum scissors, transilluminating, Bruce Cannell's technique that Tim has taught us all how to do rapidly in front. And then I go another at the 3 millimeter breath down half the way down to the neck, and then the bottom part is right on the platysma, as Joel mentioned. And I do the central neck with lipo. I don't divide those perforators. Those are Steve Hoffland's perforators, and Steve felt you could carry the whole facial flap on those 2 perforators, and I suspect he's probably right. That's where the blood supply is to the tragus, and you get into trouble when you create tension in your flap, and you cut off that blood supply. I don't believe the blood supply to the tragus comes from the area near the mouth. And I don't like to undermine that malar bag in response to that question we had in the prior panel. I just like to stay away from it. Now, what about this matter of undermining? Well, there's how I undermine when I'm not doing the neck, and there's the max lift that Alex Verpaley does, who's going to be with us in spirit, if not in person. Dan Baker's lift undermines less than mine. Certainly, Susan's extended smash undermines less. Tim's undermines the least of those 4 examples. All of them are undermining less than I'm doing. I'm going to put those patterns of undissected skin down to show you that they all fall within what I consider the safe anterior zone, beyond the thin zone, which is the danger zone for me during dissection, and in a zone of rapid dissection that's outside the perforator support of the tragus. So the section of that zone takes me an extra, 3 or 4 minutes, and I do it with the scissors, Joel, not the bovie. So I want to be upfront about facelift, not just figuratively, but really literally. And the 2 most important sutures in my facelift, it's not a religious invocation. J stands for jowl, C stands for commissure. These are the 2 most important steps in facelift. I want to treat the jowl and the commissure, thank you, and subcutaneous plication and subcutaneous undermining are my road or my highway to that end. So the 2 steps are wide subcutaneous undermining and then anterior subcutaneous plication. Well, the undermining, what does it do? Provides access for the anterior vertical suspension, which can't be done otherwise, for reducing the jowl, which I do once in a blue moon, for division of the DAO, which I do in everybody. And it increases my rhodidectomy effect. It increases my skin redraping, especially in the jowl area, as Joel just testified to. It increases effacements of the nasolabial bitterness and marionette folds. Of course, there's a theoretical increased risk of hematoma marginal necrosis, but I don't think these are practical and experienced hands. What about the anterior plication part? Well, it eliminates the jowl, thank you, and it fills the submalar deficiency with the jowl. It effaces the nasolabial and bitterness better than I could do otherwise, eliminates the marionette, eliminates it, corrects the jawline, suspends the underjaw, reverses the platysma banding, and suspends the modiolus, and with it, to a degree, the mouth. And I know of no disadvantages about working up front once you're there. So if I transpose all these targets to a map of the face, as I'm doing now, jowl, underjaw, platysma bands, mouth, they all have something in common. They all have a commonality, and it's geographical. They all exist in the paramedian zone of the face, where I like to subject them to a vertical vector. None of them are in the preauricular zone, in which I do very little, essentially nothing to the face. It's of any importance to me. Paramedian, I want to be up front. When Willie Sutton was asked why Rob Banks, he says, because that's where the money is. Well, when I'm asked why I work up front in the face, my answer is, predictably, because that's where the aging is. It's all up there. It's not anyplace else. What about the vertical vector? Well, that's important too. I favor vertical vector for rejuvenation that's perpendicular to the core of the earth. I share that opinion with another guy there. And it's not an unimportant distinction. There's as much difference between a vertical vector and an oblique vector as there is between an oblique vector and a transverse vector. Nobody's espousing a transverse vector. So I believe very much in the vertical vector. I use a vertical oblique for the skin, as I do for the posterior platysma and for the brow, but all the other 30-some vectors I use in the face are purely vertical, except for those 3. I go back to an article that was at the turn of the millennium here, and I'm alluding to what I use, which I call a fluid fixation rather than a rigid fixation. So I'm going to mention about fluid fixation for a minute. I had these crude drawings in that article that showed a vector downwards for the upper subcutaneous cheek, and there was. Most of the movement's upward from below, but and that's been criticized as a weakness in a subcutaneous technique. It's not. This is a case done in a panel in Denver, and the moderator in that facelift panel wanted to see my cases ahead of time, and then it says in the panel, well, it looks like you did something to the upper cheek. Well, no, I didn't, but it's not a rigid fixation. It's a fluid one. A fluid fixation remodels the subcutaneous plane of the upper cheek into a pleasing long radius arc or dome, which is the shape of the lower surface tension, and it does so automatically. I've done nothing above the dashed line on any of these patients, which is the line of my plication of the subcutaneous, and yet the upper cheek is changed in each of them because it's a fluid rather than a rigid fixation, and there's an automatic remodeling of that upper subcutaneous tissue, which I don't have to remodel myself, and which would be difficult. And none of those have had a drop of fat added to their cheek. So this is not a disadvantage in facelifting. It's a considerable advantage in an artistic result in facelifting, the fact that your fixation is not rigid. Within a year of that publication, these 3 cases were published in our best journals, in which the authors of each of these insisted on the importance of a rigid fixation. A rigid fixation does not automatically create a pleasing curve. At least my eye tells me that it doesn't. What about longevity? This stuff shouldn't last working the subcutaneous plane. Well, my theories there are we're close to the targeted deformity, and the targeted deformity for me is the jowl, and my blue line, plication line, is very close to it. Creep is proportional to tension or load. It's proportional to the distance that you move a load. We've got a lot of wonderful tissues in the human face that resist creep, flexor tendon, fasciolata, etc. I don't count SMAS among those. Certainly it does better than skin or fat, but I don't believe SMAS belongs up there with those tissue systems. I don't think there's probably some place about there. There's a lovingly dissected SMAS layer with a lot of holes in it from a proponent of SMAS surgery. My rule number 2 is avoid tension during suspension, because if Newton's law says that for every action there's an equal and opposite reaction, and if you can avoid that, you avoid the reaction, which is the force for recurrence. It's minimized. It leaves really only gravity over time to recreate the deformity. And as it turns out, and there's no other explanation about why my results now last so much longer than they did when I used other techniques. So here's a woman, early case, 5 years later, and she looks a lot younger. Well, everybody shows cases 5 years later that look a lot younger. And this one's a hard facelift. She's 7 years after a facelift, and she looks younger still than she did before a facelift. And you say, well, 7 years, that's no. Here's a woman 9 years after a facelift, looking considerably younger than the day before she had her facelift, having been through all the rigors of, the aging things for women. Here's a woman 10 years after who came to show me a cancer removed from the nose, and looking considerably younger again, I'd say, than the day she had her surgery. It's another example of an older patient. She's 10 years older than the day she had her surgery, and yet she looks considerably younger. So I find that the results tend to be stable over time. Here's another example. She's now 50. She was 60. She was 50, and she looks younger. She looks prettier too. Here's a patient 13 years after a facelift, and you can see that the facial architecture, although she's having some re-aging, is holding up well. Here's one 14 years later. She's now 60. She was 45, 46 when she had her facelift, and she's younger than she was at 46. Here's a woman who was doing well until she fell down the stairs and was in a coma for 3 months, and she had a stroke on one side. But if you look at the non-stroke side, because I only did a mini lift on that side, I had to do the whole other side of the face over. It's held up very well after 16 years. For 18 years, and this is long before I was doing fat grafting to the face, I don't suggest that woman's younger, but she sure isn't much older, and now she's 70 compared to 52. Or this woman, who's got much improvement after 21 years in the redundancy of her nasolabial and the redundancies around the corner of the mouth. You see what fat grafting would have done to her eyes would have been stable and remarkable, but of course I wasn't doing that then. I don't even think Sydney was. So these tend to be stable for me, and it's not just an occasional selected case, but it seems to be, in general, true. Now, when making the bed during facial rejuvenation, helps me in reversing these 4 persisting paramedian pathologies. What are those? Well, the nasolabial, the bitterness fold, commissure slump, the jowl and its marionette, and of course the paramedian bands of the neck. When I undermine over 2 of these structures, I feel I have a lot more influence over them. I like to do a brief microliposuction on these nasolabial challenges. This is a woman who's focusing on it because she only has her nasolabial on one side of the face, so she's not going to be happy with a 50% improvement. She really wants it reversed. The hardest thing and all the most difficult thing, the thing we don't see so often in facelift docs, are these mouths that do this, these mouths that look like torn pockets. And again, undermining all the way over allows me to get my hand on those structures, on the commissure, on those regions around, those areas around there, and that to me is an enormous advantage. With respect to the platysma band, this is just the first mini lift I did once I developed my little platysma suspension, which I'll mention in a minute. And I didn't divide her platysma, which is what I generally do, but that wouldn't have been able to be accomplished had I not undermined the skin over to the fold. So undrape is important in my philosophy. Just a touch on, we spent a lot on the mouth earlier, on the eyes, let's just touch on the mouth, because it is so important, it's so overlooked. And again, mouth position is much more important than what I do to the shape of the lips. And it's hard, unfortunately. I wish it weren't. It is. These are the steps I do when I try to treat the mouth position. Number 1, one's automatic, because when you lift the jowl clear across the face, you're really doing a lot to help the mouth position. And to me, that's the most important single thing I do for the mouth is my jowl lift. And then there's the vertical rotodectomy. Those of us that use vertical directed facelifts all bring a little help to mouth position when we use that vector. But those are intrinsic. The others are optional, and I embrace most of them. I divide the DAO, as I mentioned, about there where you see it, as Claude Laurent first described. And I now hit the upper border of that for a little additional effect. And I hit the chin muscle in virtually everybody. I free the chin because it's such a universal component of facial aging, and bring it up. I release the depressors of the lip without cutting them at the periosteal level. That's Christian Marinetti's idea, not mine. He's a Frenchman from Marseille. And I take a piece of mucosa off above the commissure and close that transversely in virtually everybody. And most recently, I'm doing something under the base of the nose, but I'm not showing cases from that, so I won't get into it. But going to a facelift talk is a little bit like a basketball game. You see a lot. Everybody takes the easy shot, slam dunks and layups and free throws and what have you. But I don't tend to see a lot of 3-point shots in facelift talks, and that just occurred to me a while ago. It's hard to get that basket, and the 3-point shot in the facelift is commissure slump. So I looked in the literature and found only the best top sources, cases with mouth problems done in the last 5 cases in the last year. And these are all recently published cases, and it looks like when we do them, we don't always get them as improved as we should. So you're going to see some air balls there. Sorry. This is a patient who, after her facelift, looks like she got something bad in her salad. This is not good. This is a patient with the same sort of thing. This is not good. These are the best names. These are names better known than mine in this field who have produced these results. And so I think it's time we give a little more attention to the mouth and specifically to the commissure. This is a case I did more than 15 years ago because it was before I was fat grafting the lips. And I didn't publish it, it was just a case. Here's another case soon after I began fat grafting the lips, so that there's a little added element there. But the overlooked mouth, it's so important. I don't know why it's been so overlooked, but it tends to be. It just brings her face alive. It's far more important than what I've done to her eyes. This woman looks depressed. Well, she was depressed after an accident as well as aging, but she would continue to look depressed if her commissure hadn't been addressed. This woman's one of the sweetest women you might ever hope to meet, but you don't know it by looking at her because she's had bad surgery in her commissure. This man asked for the most change I could give him for his facelift, an unusual request from a male. And I'm going to bring out the patient with the cancer from her nose again. Here she's a year after surgery, and she looks quite pretty. And she was a model when she was young before she met her husband. And I just ask you, 10 years later when she comes back in to show me her cancer, who does she look more like? Does she look more like her 20-year-old self, or does she look more like her 50-year-old self? And I'd say the latter, and it all has to do with the mouth. So put the mouth on your radar. It's time. It's overdue. Let me talk about the neck a minute. It's way down there at 4, and I know that disturbs a lot of you. The jawline, by the way, is a little more important to me than the underjaw. But I'd like to go on at this length a bit. Maybe Jim will want to on the panel, but we meet face to face. We don't meet neck to neck. So the neck is not more important than the facial features for me. But it is important because a masterful neck correction cannot salvage an indifferent facelift result. But I promise you, an indifferent neck correction can most certainly and most predictably scuttle the best of facelifts. So there's no place for marginal improvement of the neck or compromise of the neck. And although I've given up my submetal incision, you cannot do that if you compromise your result. It's a bad trade-off. So I look at autocorrection of the neck using this Paramedian vector. Now, I'm not a SMAS expert, but I have treated the low anterior mobile SMAS for a long time. I don't know much about the fixed or the high SMAS. And vertical Paramedian elevation of jowl fat alone, no muscle sutures, resuspends the lower mobile SMAS and platysma of the anterior face and neck. It does, not with these popular vectors. No, it doesn't do it with these, but it does it with this vector that's up front and Paramedian. So it's my job to try to convince you that. So I did a series. I had to look into this, and I did. Here are a series of patients who had nothing done to the neck except liposuction. Her neck wasn't touched except liposuction. So it's the impact of lifting the jowl and the subcutaneous plane that's corrected her neck. None of them have had anything done below the dotted line, except a few have had liposuction. This one also, secondary case, nothing done below the dotted line. So if you're trying to get neck corrections and give up a central scar and incision, it helps if you use a facelift, which helps the neck intrinsically, and this one does. In fact, I would suggest that this brings more improvement to the SMAS than traditional SMAS facelifts bring to the SMAS. At least I haven't seen SMAS surgeons show unoperated necks like this after their SMAS suspensions in the face. This one after the third procedure, and there's multiple problems with the neck, and the neck wasn't open, it wasn't touched. Now, I don't advocate this, because of course these are selected cases I'm showing you. But I'm showing them to you so you understand the power of an upfront vertical vector and how it not just helps the face, but it helps the neck alone. So then my subsequent steps to try to do the neck without the traditional approach are more achievable because of the facelift that I've chosen. Platysma aging and its reappraisal. And again, there's a paradigms and paradigm shifting. With youth, of course, as we age, the platysma marches toward the midline, the jowl comes down with it. We then have the option of continuing the march. And the first question this really was over the French, particularly Daniel Labbe, and I think and I like to do it by simply lifting the jowl. What's good for the face is equally good for the neck, would be their, which is the vertical vector, returning the neck to the displayed natural anatomy of youth. And Daniel Labbe, of course, went a long way in our conceptualization of this. And I began with the Labbe suture, and I modified it heavily to the suture that I now use posteriorly. Why is this necessary? Well, back to Brian's picture, there's something that's going on behind that wonderful glide plane, and of course it's the platysma auricular fascia of Furness, or the fixed mass. And to treat the lower SMAS or platysma, Labbe had the idea of reaching over all of that, just bridging it, and it was the right idea, and I now do that. So my platysma hitch, heavily based initially on his, such as this. I'm 2 finger breast below in the neck. I divide the neck muscle member in 80%. I divide it the second time up front, 70% in that same group. I then test the muscle movement near the angle. It's usually 3 centimeters down, 3 centimeters forward. I palpate the lowest point of the mastoid tip, and then I use a heavy suture, and this is tension. This is old-fashioned facial tension like I used to use, but it's in the neck. I then have a trailing sutures of 3-0 that do those. They bring the cut end of the muscle backwards, and they bring that little island of muscle up toward the angle. So this is my ABO approach to rejuvenation of the neck now. In the O neck, the clinical findings are early laxity only. So the surgical treatment, as you might guess, is nothing except elevating the jowl, as you've seen from some of those necks before, which were pretty advanced neck challenges, and they responded to that alone. Here would be a typical case. She needs nothing whatsoever, no surgery carried beyond her mandible border, and we can have a predictable improvement. But what about when things deteriorate across the neck and the transverse? Well, that's my A neck. Those with transverse deterioration respond, I think, to a Labbe-type approach. Fixed vertical bands do not. So I deepen the premium of the undermining posteriorly to accommodate my suture now, modified from Labbe's, and I'm still doing my forward suture, and but no need to divide muscle and to extend my undermining. So that's my A neck. And now my B neck. And this has been a long evolution for me. Evolutions for me are slow in aesthetic surgery because you can't take big steps ever with any patient. When there's a fixed band, I've got to undermine beyond that band, as you see. And if it's a fixed band, it's going to get divided, as I've done through most of my career. And I'm twice divided up front now because I'm at a disadvantage working from the side. I've got more control of things up front. I'm just not willing to make the incision anymore. I don't like the vector anymore. So here's a B neck. Because I'm so focused on the commissure, and it's so difficult to improve these things, I don't want to compete with that by pulling the SMAS in an opposite direction. But I'm not a philosopher. I'm just a stupid surgeon. And what I really care about is what works and what doesn't. Don't compromise your neck result by giving up the central incision. It's not worth it. That's a foolish choice. On the other hand, if you do give up that central incision, it does force you not into that vector, but into these vectors, which are much better for the face if they accomplish your goal in the neck. Now, there's another question that pops up, therefore, which is, do most successful neck strategies truly require submetal incision? Well, for many, many years, and look at that neck by Jim Dow, I thought for so many years, but if not, there's rewards from eliminating that incision because it forces you into the proper vector for the platysma, the SMAS, the skin, particularly the jowl and the commissure and the lower lip and the bitterness fold. All of these things become forced vertical vector, which is correct. And it eliminates a scar, which is worth something. It saves a little time, saves your poor old back from leaning over that nasty little incision, less hematoma extent and less tight neck sensations for your patient, maybe a little less overcorrection or naturalness. There's a danger, though. And the danger from eliminating that incision is simply neck undercorrection or treatment failure, and it's not worth it. Don't do that. If you feel you're not getting the neck result you did before working under the chin, by all means continue to use your submetal incision. It's been a long evolution for me to give it up. And even now, I feel like I'm not quite there. Now, in the fact grafting orbit and mouth for me on everybody, as we talked about yesterday, I don't do anything in the face in 75% of my facelift patients, so I'll talk about that group first. These are truly architectural facelifts. They're volume neutral. I'm restoring architecture. Here's the first case I did, where I dropped my mid facelift, which I used to do on everybody. So this is a Paramedian lift alone. It was also the first case I fat grafted because I was out of the periosteal plane for the first time in 6 years, and that's the only way I could get the fat in. Notice that the commissures are responding even back at the first case. Notice that the architecture is responding, taking on the inverted cone of youth of that properly positioned egg. Notice why she was the first one I gave with the midface. Doing the midface on this woman would have been crazy. Look at her cheek distortion. And look at the effect of, again, non-fixed but fluid fixation, how that remodels that cheek and gives her a softer curve and remodels that whole facial profile. Look at the commissure. That's a double dip profile. That's an OG curve on the right. I want to see that after every facelift. I've added nothing to her jaw, but it looks like I might have. I haven't. And I like to kick out lips. Even back then I was doing lip, and of course we want to help the lower lid, as you see. Back then, yeah, I opened her neck. That was unnecessary. But I didn't know it then. Here's a patient who's had a facelift the year before. Let's look at her commissure position. Very important to her overall result. She felt she got nothing from her prior facelift. And her commissure again, because I'm working up close to that structure and I can get my hands around it. And I'm not trying to treat it 35 yards away. It's with some distant mechanism. And I'm going to simply replace what is normal position and retain it there. I'm a Millard trainee. My mother said it more succinctly some years earlier. Put that back where it belongs. I heard that a lot as I was growing up. And the jaw belongs up there, under the malar curve. And we go from a double dip to a pretty OG curve. That's good architecture. Nothing added to the jaw. Looks like something might have been. Wasn't. Not in any of these. Not a drop. And her smash was improved without touching the neck for the reasons we've just described. Here's a secondary case. And let's see what the commissure does. Yeah, our commissure's better because we're working up front. The architecture becomes rather ovate. Yeah, like the egg. How did we accomplish that? By lifting the pillow only. When she relaxes her mouth, she's got a better dental display as well. The lower lip's been enhanced. Of course, the eyes have also fat grafting to the lids and lips on everybody. Her nasolabial's improved to a worthwhile degree. The commissure, again, has. Let's look at that architecture again. There's the upside down egg, and there she's got the shape of the egg. It's pretty close. And nothing zero, nothing added to the face, not a drop. Accomplished how? By lifting her pillows. Double dip becomes a pretty OG curve. Nothing added to the jawline at all, simply lifting the jowl. There she is as a young woman with an inverted cone of youth, with eyes and mouth and lower lips that were very much as they were when she was younger. Notice that the lips kick out. They don't thicken. I don't like to thicken an upper lip, ever, hardly ever. Never say never. I lift the chin on almost everybody. It's part of the aging process. Look at the under eye. And again, nothing done to her neck. She was one of that group, except the liposuction. Again, we've given her a lip. Notice that her eyes open simply by adding fat to the upper eyelids. Interesting. There's her inverted cone of youth, simply by lifting her pillows, nothing else. No fat added. No other manipulations. Flat cheek becomes, well, let's look at her commissure first. Yeah, we're working close to the commissure. We get a handle on it. How about the architecture? Well, yeah, we flipped her egg pretty good. Inverted cone of youth. Nothing added. Just the pillow lifted. Double dip becomes a pretty curve. Nothing added to her jawline. I like the jawline to remain delicate, particularly in women. Upper lip kicks. That's appropriate at any age. You can see the improvement of the lower lid. Chin's up. That's good. That's part of the descent process along with the jowl. Almost ubiquitous. And we liposuctioned her neck. Here's a woman. Subtler changes. Very little fat to her face. That's a long story why. That's an early promotional picture of herself. She's looking rather like herself at that age. Look at her architecture change simply by lifting her pillow. Not a drop of fat or other manipulation has been done. Notice again the prettiness of the curve because I haven't insisted on a rigid surgical fixation. And I don't see my... And look at her jawline as if I've added something. I haven't. I've lifted the jowl instead. And her neck has been improved. Her chin position has been improved. Neck has been improved with that posterior modified suture of Daniel Labe. Do I enhance faces? Of course I do. 25%. Everybody would add fat to this woman who's never had surgery. And it's life. It saves her. And by the way, I don't use any more eggs because when you start putting fat and implants in the face, you can get any architecture. That's not telling you anything about your base facelift, so we won't do that one. But let's look at her commissure. We've got her mouth, much improved. Eyes, much improved. Not perfect. She still has a little residual bowing on that left one. So that was a little bit of a lapse. Corner of the mouth, much better. She was an early case, so I did less fat. That's only 3 cc's. It wasn't enough. And 2 years later, she came back and asked for more. Start off slowly with these things. Nothing added to her jawline. Nothing done to her neck. Neck not touched in any way. Eyelid better. Smash improves simply by lifting her jowl, period. Nothing else done, no surgery below her mandible. This woman, well, there's not a lot of aging there. She's got that stare, if you remember. We're going to fill her in her eyes, but she doesn't have jowl. If you're going to help her at all, you're going to have to do it by adding fat because she has a very lean face, and she wanted a big cheek because she used to have a big cheek. What's the proof of that? Well, her wedding picture 25 years before, and now she has the same cheek she used to have when she was 25, and she's rejuvenated, and we couldn't have done it without adding fat in this case. So sure, from a double dip to a pretty OG curve. See the improvement of the eyelid? No, I didn't do her nose. Or this woman who comes in saying, not pretty. I used to be pretty when I was younger, and I wasn't ready for this so early in my life. So we can soften her face with fat. We can exaggerate her lips, which is good, a lower lip for women. And we can push the fat a little bit, because 5's a lot for me to put in the cheek, so we have. Her commissure's better. But she has a softness to the face, and there's a femininity now that exudes from the face that before it was sort of lost from her face, and fat is critical for that type of a conversion. And you notice that not only notice that the noses always look a little smaller when you fill the suborbital zones in at least the profile view. Nothing done to her neck. So these are enhanced results. Do I go beyond that? Yes, I do transformative fat grafting, but in very selected patients. This patient is an early example before he was doing fat grafting. Overly thin, I was doing an abdominoplasty at the same time as her facelift, so I put multiple dermal fat grafts on the abdominoplasty interface. I've since added small amounts of fat from her face, so she's younger now than she was when she was. And that one you saw before, but look at her black profile. And of course, we've got to get her commissure up. But there's an unnaturalness there that only fat can help, I think, in my hands. I just can't do this by traditional lifting alone. So fat is the hero. For that, as with this patient who's had many bizarre things done, including given a larger upper lip than a lower lip, that's always stupid, just isn't right. And upper lid has to be restored, the lower lips, the upper lip has to be carved down, the lower lip has to be filled. We've got to add mold. A lot of fat in this face. For this woman also has had a lot of things done so that she no longer resembles herself or family members. And here fat becomes a major, major force. And without it, of course, you simply can't reverse this kind of, it's a deformity truly, because when you see her in her early 30s, now she looks like herself again, although she's significantly younger, because this is a woman in her early 30s headed for early aging. So fat's wonderful. And I use it in a transformative vein when necessary, but not often. Here's a young woman who's almost beautiful, and we do 30 cc's of fat, and she becomes beautiful. That's all. It's a quick recovery. No surgery at all. There was lasering of the lids, because I'll laser everybody's lids once if I get a hold of them. And now she's really quite beautiful. And it's just fat that's tipped her over that tipping point to get her from the one point to the other. And some of these patients will come back and want more. You have to resist that. They think it's so magical. They want more. No, I come back to most of them without fat. This is a heavy-set woman. This is, I consider, a hard facelift. We've added nothing. This is volume neutral. No fat, but fat to the lids and the lips, yes, but not to the face. And I wouldn't have wanted to add fat to her face. And we've got enough of a change on the basis of shifting her fatty volumes within the face to make this a successful facelift. And much the same with this patient also. Again, nothing's added to the face. This is a volume neutral facelift, and we've simply taken her pillows and put her pillows back at the head of the bed. I hope I've answered my claims about architecture, about the commissure, about SMAS, and about longevity. But if I haven't, I thank you for your attention in any case. Thanks a lot.